Thank you.
Thank you, sir.
Next, we'll move on to Dr. Krupa from Medicine 1. Don't go overboard.
Good morning, everyone. I'll be presenting from Medicine 1. Don't go overboard. Presenting Mr. V, a 17-year-old gentleman from Chattur. He presented with chief complaints of alleged history of snake bite. History of present illness. He was apparently well till a day before admission at 4:30 p.m. when he felt a pain on the dorsum of his right hand while sitting on his field. At that time, he noticed a blackish brown snake slithering away. There was bleeding from the bite side that was noticed, which lasted for less than 5 minutes. There's no difficulty in opening his eyes, lifting his hands and legs, no difficulty in breathing. There is no history of any blood in urine, bleeding from gums, blood in stools, or any prolonged bleeding from the bite side. He was taken to a local hospital where he was given 2 IM injections, the nature of which is not known. WBCT was documented as positive and he was started on 10 vials of ASV. At around 7:30 p.m., this is around 2.5 hours post the ASV, he developed chest tightness, abdominal pain with sweating, increased sweating. He got up to go to the washroom and he had a loss of consciousness and he slumped to the floor. His BP was noted to be very low and he was referred to CMC for further management. Past history, he does not have any known comorbidities. On examination in the ED, his pulse was at 80 by 40, BP was at 80 by 40, pulse at 110 per minute, respiratory rate of 28 per minute. He was febrile, 99.8 degree Fahrenheit temperature. There was no pallor, ictus, clubbing, cyanosis, lymphadenopathy, or edema. There were fang marks on the right dorsum of the hand, but there was no swelling or any local erythema that was present. CNS examination was normal. Per abdomen was soft and tender. There was no organomegaly. Respiratory system, he was mildly tachypneic, but bilateral normal vesicular breath sounds with no added sounds. CBS was also within normal limits. Any differentials you can think of? I'll just go ahead with the. So basically, there are no clinical features that suggested animation. Basically, patient did not have any prolonged bleeding from any side. There was no neurological manifestation. But what has happened is there was patient WBCT was documented as positive, which we are not very sure as to what exactly happened. And I'll go ahead with the investigations that we did. The HB was at 16.5, WBC count of 5,000, platelets of 4 lakh, LFT was within normal limits, creat of 0.4, sodium 135, potassium 4.2, urine routine was bland, ECG was normal, WBCT done 3 times here, 6 hours apart was all negative. PT, APTT, INR was within normal limits. So basically what has happened, we at an age of 17, we were not looking at any cardiac or CNS things that have led to that episode of syncope. We were thinking of the ASV that was given and probably an anaphylactic reaction to the ASV that was given. So just wanted to touch.
You don't have features of anaphylaxis. You do not develop hives.
Yeah. So
bronchospasm, stridor.
Right. So there are different manifestations of anaphylaxis that are described with respect to ASV. So this is a paper published called Adverse Drug Reaction Profile of ASV in a rural tertiary care setting hospital. And this is something we've noticed. Generally, the frequency of antivenom reaction, primarily patients presents with chills, rigors, nausea, vomiting, itching, urticaria, hypotension, and respiratory arrest. This is the spectrum that patients generally present with. And dose of ASV, at higher doses of ASV, there is a higher chance of patients developing these reactions. More than 150, not a lot of studies have been done. So the spectrum types of reaction that can occur with ASV, that's what I wanted to. The early anaphylactic reaction usually occurs within 10 to 180 minutes of starting the antivenom. It includes urticaria, itching, cough, nausea, vomiting, abdominal colic, diarrhea, and tachycardia. This is what we generally look for in our patients when we give ASV. Minority of the cases present with fatal anaphylaxis, hypotension, bronchospasm, and angioneurotic edema. They occur due to the direct activation of complements by IgG and residual Fc fragments, or direct stimulation of mast cells and basophils by the antivenom proteins that are there. It is not necessarily an IgE mediated type 1 reaction. There's something called a pyrogenic reaction. It usually occurs after 1 to 2 hours of starting an ASV therapy. It generally presents with fevers, rigors, chills, hypotension. So this is what we were suspecting our patient. Our patient did have an episode of fever, which was followed by a hypotension. There's a vasovagal attack. There was a hypotension that happened, and that is what led to the patient falling and coming to the
anaphylaxis. So please go back to the previous slide. What did you say? The last sentence.
These are direct stimulation of the complements by the proteins. It is not necessarily an IG type 1 reaction that happens.
Anaphylactic reaction. Hypersensitivity reaction.
The other thing is there's late serum sickness type of reaction. It's a type 3. Generally develops 1 to 12 days. There's an mean 7 days. That is the generally described time. The clinical features include fever, nausea, arthralgia, myalgia, arthritis, mononeuritis multiplex, recurrent urticaria, lymphadenopathy, neuritis, and even encephalopathy. They usually respond to oral antihistaminics. Management of this is primary drug of choice is adrenaline. We can give steroids, IV fluids, and antihistaminics. In our patient, he was given 1 dose of adrenaline at admission because of the hypotension that was there. Then he was started on NORAD infusion. He started on stress dose of IV hydrocortisone. Supports were slowly weaned off. Patient did not develop any similar episodes. Anti-snake venom should be used judiciously. Whole blood clotting time, positive or negative, that needs to be really monitored before we start the patients on ASV. Anaphylactic reaction can happen after an interval of administering ASV, so that needs to be looked for. Adrenaline is the drug of choice. Even here, the ideal thing to do would have been to give bolus doses of adrenaline at regular intervals to pick up the BP. We just gave 1 dose and we later started on NORAD, but the ideal drug of choice is adrenaline for anaphylactic reactions.
Your patient, the patient had seen the snake, is it?
Patient had seen the snake, but patient could not describe. Patient could not describe it.
He knows that the snake has bitten.
Yeah, there were fang marks.
There are fang marks with bleeding also from the side, is what you said.
Yes.
And the patient has gone to a local hospital and WBCD was done, which is positive.
Positive.
Why can it not be a actual snake bite with envenomation?
The
which was
bleeding
treated
was
adequately at that time? Why do you think it's just an anaphylactic reaction and rather not just a snake bite? Which, yes, you can have an anaphylactic reaction even with snake bites getting treated with ASV, right?
The clinical profile, there was no other, the bleeding that happened even at the time of snake bite was less than, it was just few drops of blood, just lasted for less than 5 minutes. This is prior to the administration.
Was the local reaction?
There was absolutely no local reaction when the patient presented to us. There were just the fang marks that were there, no erythema, there was no swelling.
Fang marks typical for a snake?
It was typical for a snake.
Did you consider other bites, any other bites which could be cardiotoxic?
We did not, because of the clinical profile that was there of the patient seeing it, we did not actually consider any of that.
Any other questions from the audience?
There was no prophylactic adrenaline that was given. It was given, so we had it was given at a government setup. The ASV was given at a government. So they had given, AVIL was given, but there was no adrenaline or hydrocortisone that was given. We've not done a D-dimer.
Other questions, we'll move on to the next presentation. Thank you, Krupa.